thank the organizers for all the work they did, and in fact specifically recognize Florian and Sonia, I hope she's in the room, for all the meeting planning they did, not once but actually twice for this meeting. I think it's an important meeting, and I'm happy to be here in Paris to share some things with you. My topic was oral mucositis, and we had talked about other topics, but maybe another time. So what I'll try and do is move ahead. Maybe I need this. Oh, just a sec. How do I shut this off? There, okay. I'm good. Okay, disclosures, really none are specifically relevant to what I'm talking about today, so I'll just skip that. I'm not sure how you introduced me, but I'm pretty sure the only dentist in the room, so I thought I would sort of set the tone a little bit by saying that really oral care is part of this whole continuum of work for cancer patients, excuse me, and it starts from the beginning at times of diagnosis for head and neck and some systemic cancers that may occur first in the oral cavity. So it's before, during, and after therapy. Obviously, I'm focusing today on one of the acute complications, mention a bit about the chronic, and then talk about impact a bit later as well. And I noted that yesterday this was some of the overlap of oral function follows into nutrition clearly, and it does with the comments of the most recent two speakers before me. And Paolo, the reason there were no questions, it was such an elegant presentation. So why does mucositis matter in all of this when we're dealing with potentially fatal diseases? Well, like many of the toxicities, it's common, it's debilitating, it's painful, and it affects function. In fact, patients care because it hurts. We care for other reasons because the pain affects intake and nutritional status and even oral intake of medications, for example, so that it changes the intensity of therapy in some cases and can prolong hospitalization and lead to intensive care. It can delay treatment scheduled and reduce or discontinue treatment itself. All this can affect outcomes of therapy as well as quality of life. There's cost drivers in there, the hospitalizations and some of the other management of the complications. And also I just wanted to mention, fitting with what Paolo mentioned, is that acute mucositis may transition into some chronic complications that affect survivors on an ongoing and maybe indefinite basis. So again, what is the impact? Well, there's an association of many of the molecular mechanisms with the other symptom clusters that we've talked about, like fatigue and depression. And they share a common pathobiology at the systemic level. The true incidence, as Paolo had mentioned, of oral mucositis is probably underrepresented and underappreciated. Most clinical trials, it is not the primary endpoint. As Paolo mentioned, clinical trials tend to report global scales, usually based on patient report, and then all those steps that he showed about reporting have an impact on how often it's reported. And I think the example of Kepivance with respect to mucositis in the Bonner study is a very excellent example. But oral issues in general are underreported by either the patient or underassessed and interrogated by the medical providers. So we, and this was also mentioned, tend to underestimate the impact on the patient themselves, and that's why PROs are so important. So all of this, mucositis can result in pain on swallowing, speech, function, and patients that have been through this in surveys that we've conducted have reported their, progression through the cancer therapy continuum in terms of what they could do. For example, brush their teeth, take oral medications, take in oral food intake, and that has a dramatic impact on them. And we don't know the estimate of how this may affect other populations, including the elderly, also mentioned by Paolo. So I'm going to show you just a couple selected studies about impact of oral mucositis. This is in head and neck cancers. This was a single study at MD Anderson, 103 patients. And basically, the mucosal ulceration as recorded in the record, not in a study, but in the record as mentioned earlier by either patient report or physician attention, was associated with increasing opioid analgesic use, increasing weight loss, and increased use of feeding tubes. radiation therapy delay in a small subset of patients at Anderson. So those are some of the impacts. Another study that was a retrospective review of 204 patients looked at mucositis present in 91% of head and neck cancer patients, which I think is more what we would anticipate if we were doing a prospective study. That 66% of these are grade 3 or 4. We know that combined chemotherapy with radiation increases that toxicity and the duration as well as the severity, getting back to that area under the curve comment that Paulo also made. Oral mucositis is more common with combined chemoradiation therapy with an odds ratio of up to 8-fold. Altered fractionation also increases that risk to 6-fold. Severe mucositis, again, in this study was associated with pain, with weight loss, and in this study they looked at potential cost of care at that institution, and severe mucositis was an estimated $6,000 additional cost in head and neck cancer patients. There are some economic studies looking at the impact of mucositis in transplant settings where the costs are much higher. One of the stories about that is the biggest economic evaluation was done in Boston, where maybe things cost more, but much higher than in head and neck. This study looked at 75 patients at 6 centers and found basically the same thing, that radiation and chemotherapy resulted in severe mucositis in about 2/3 to 3/4 of patients. Opioid use was high in about 85% of patients, yet pain report continues, which is a comment on our efficacy in managing pain once it occurs. Resource utilization, again, tube fitting, hospitalization increases, and increased length of stay. These are all big cost drivers in any system. Okay, so picture of ulcerative mucositis, that's radiation-induced, and this was one with chemotherapy. And just one comment on this slide is in the corner of the mouth. I don't know how well you can see it, it's pretty clear here. There's evidence of candidiasis, so treating both the mucosal damage and the secondary infection will have a greater impact. Okay, so this is, I mentioned, and I think this is just interesting, a study that looked at the impact of mucositis on the healthcare providers. And this was a survey of radiation oncologists and radiation nurses. And what they looked at, and the summary is that last line on this slide, is the radiation oncologist spent approximately 7.2 hours, nurses 12.1 hours managing mucositis. And this increased as their travel through the radiation therapy progressed and symptoms developed. So there's a number of impacts in the system, and in fact the cost of care should be looking at an analysis of professional time in that management, which is rarely studied. An impactful acute symptom during therapy. The pathobiology of mucositis has been described by Steve Sonis as being in basically 5 phases. The first is an initiation with immediate release of reactive oxygen species. It's a connective tissue and an epithelial process. The next phases involve upregulation of those pro-inflammatory cytokines that are probably correlated with many of these symptom clustering that we've talked about. Phase 4 is ulceration, where the microflora in the oral environment has an additional impact that can also upregulate the cytokine release. And then there is healing. We've spent most of our time trying to look at prevention and symptom management, but virtually no time at healing. So as we break down these phases of the condition and we looked at the molecular mechanisms of that, we are now able to start to drive clinical trials that are looking at mechanistically affecting the process, potentially at different phases. And one of the differences between chemo and transplant-related mucositis is those are usually acute episodes where, in essence, you may be running through this process of mucositis damage and healing in a linear fashion, whereas in head and neck cancer therapy, there's repeated small radiation exposures punctuated by additional chemotherapeutic toxicities at different intervals. And so in that setting, we're probably seeing multiple phases of this tissue damage and repair ongoing throughout the course of therapy, which will probably need to change the way in which we administer therapies in those populations, assuming they're similar, and once we have them clinically available. So the studies need to be a little bit more intense. And this has been mentioned by everybody, so I'm going to go briefly. Targeted therapies have an effect on oral mucosa, as do the immunotherapies, where actually, interestingly, from the oral standpoint, we have a little bit more experience with oral graft versus host disease being an immune-driven oncology condition where we have some pretty good ideas about how to manage that currently and some abilities to do that. So I'll just skip that to the next one. This is an example of mTOR, and it's already been mentioned about the aphthous-like stomatitis that occurs, and the approach to management thus far has typically been steroids, but we certainly will have other choices as we look at mechanisms. Okay, so what I then wanted to do is just summarize the MASC ISO, which is Multinational Association for Supportive Care in Cancer, and the Oral Oncology Group that's part of that organization. And of course, the ad is that you saw earlier, the meeting is in Adelaide in June, which from what I hear will be somewhat like the weather today. So for those who are coming, bring your Gore-Tex or your umbrella. But it'll be a great meeting, they always are. So this is the guidelines as of 2014. These will probably, it's almost time to start reviewing the process to update them. But basically recommended, so these are a level 1 or 2 evidence approaches. One is cryotherapy, which is just sucking ice for certain short half-life chemotherapeutics, like 5-FU given by infusion. KGF1, which is palifermin, is used in and indicated and FDA approved for auto stem cell transplant conditioned with total body irradiation and chemotherapy, and that looks great at level evidence too. We just published a paper on a single center that I am at on KGF1 for allogeneic stem cell transplant with clinical benefit, but it's not in anybody's guidelines to date. The other therapy that's been popular with increasing evidence is low-level light therapy or low-level laser therapy, LLLT, better known in Europe and Brazil than it is in North America, but we are really looking at this seriously, and it is recommended for prevention in stem cell transplant, and I'll mention about the suggestion for use in head and neck radiation therapy. An interesting potential intervention for a number of other tissues, including repair. So wound healing may be part of where laser light therapy may be beneficial, and there are some clinical reports becoming available. In the first level of evidence, recommended again for prevention, is benzidamine, which is an EU product originally from Italy, with evidence for standard dose radiation therapy. It's not been studied in other fractionations or other combined therapies. So recommended for treatment of pain, or of mucositis, is really pain only, and it's PCA for stem cell transplant. And then suggestions, less strength of evidence for good oral hygiene, good brushing, atraumatic diets, good oral care standard protocols, level of evidence 3, meaning it's mostly opinion-based. Oral cryotherapy, again, for high-dose melphalan and stem cell transplant had level evidence of 3, and for radiation therapy, the low-level laser is also mentioned in the guidelines. For pain management, transdermal fentanyl was promoted, and we also have guidance for topical interventions for pain management, and you're starting to see more data on topical morphine or morphine mouth rinse, 2% in head and neck cases, and doxepin rinse, which may start to address some of the neuropathic components as well as the pain effects. And those studies are ongoing and more to come. But the principle is that if we're damaging oral mucosa locally, especially in head and neck patients, or if the pain complaints are greatest in systemic chemotherapy in the mouth, that we might be able to affect it locally as well as the more traditional systemic drug delivery. Recommendations for prevention, we have mostly recommendations against. In other words, evidence that shows it isn't effective. So antimicrobials were at one point thought to be a real driver of the conditions, so the oral flora was thought to be a key player. It turns out it's probably more a tag-along, it's a secondary effect. So the various antimicrobials in the form of lozenges applied topically and as rinses like chlorhexidine and other molecules have shown to be not effective. And that really reinforces that the bacterial component is probably secondary. Sucralfate has had conflicting studies, but in the majority of cases it's ineffective, and so it's not recommended for prevention, although in some cases that might coat the surface, causing some reduced symptoms. Again, recommended against use for treatment of the condition is sucralfate, IV glutamine, which typically is sort of promoted in the nutritional view of things, but has been shown to not be effective in the majority of studies. So again, now suggestions against use. For prevention, there's a suggestion to not use any of the products on this slide because they haven't shown clear efficacy, and that includes chlorhexidine for mucositis, but not for oral hygiene purposes. GM-CSF mouthwash, misoprostol, an anti-inflammatory, pentoxifylline, which we had some hope for at one point, which is an anti-TNF, but that has not panned out for mucositis. And stimulating saliva, which pilocarpine can do, does not show an effect. So just getting right close to the end while the bells are going, trends in oncology therapy are affecting what we do, just like everyone in the room. And there's increasing toxicity in head and neck cancer therapy, and you've seen some of this. But there's also decreasing toxicity in stem cell transplant with protocols changing, and some examples are mini transplant and reduced intensity of conditioning. And Kepivance, which is the first, or KGF, the first growth factor shown to be preventive. Oral care and cancer therapy, we need to have developing interventions, so those are coming. I'm going to skip this and talk. Just wanted to end with this. And even though it's an English poem, this is written by a patient. It was published in the New England Journal, late 1980s. But this patient, I'm going to point out a couple lines. One is, a fishhook lodges in my throat. So that's how her throat felt. And almost down at the bottom, if I can point with this or this. Let me find the right button. There we go. Okay, is the tongue becomes a rest on the teeth, but the teeth feel like enemies, and they're sharp and like barbed wire. And she says, and only moans escape my lips. I cannot eat or speak, which I mentioned in follow-up with patient report. They describe the same thing, that those measures of recovery from the injury is recovery of these functions. Only moan escapes my lips, inside a hall festers, and pain lengthens time. So I think I have to end there, and thank you for the invitation.
Thank you very much for your talk. Avez-vous des questions à poser à nos deux orateurs?
Thank you very much for your talk. Do you have questions to ask to both our speakers? Paolo, you have a question?
Thank you very much for this excellent presentation. I would like to know, as far as you know, is there any trials reporting a correlation between the grade of mucositis and the outcome of the patients? That you know that there was a paper published in JCO last January that told no pain, no gain. Is it true also for mucositis or no?
I think in answer to your question, which you probably have a comment or an opinion on, I don't know that there's that evidence in the chemotherapy, but there certainly is on the EGF use with like in the Bonner study and the studies since. So evidence of an effect, I think with the growth factors is true, but on the other side, I don't know that that's there. Do you have an opinion? No. Okay. Great.
I talk in French or English? You hear? Sinon, oui, c'est bon? Donc en français. On vient de parler de patient-reported outcomes.
We just discussed patient-reported outcomes. It is important for the patient to properly evaluate his own symptoms. But for that to happen, we need therapeutic education. We need to teach the patient to evaluate his own symptoms. In the last sentence, in your last slide, there was talk of organizing mouthwash. And as part of patient-reported outcome type programs, isn't it better to focus therapeutic education on patient assessment, but also learning how to mouthwash? I know they do it for ENT, but rarely in oncology. Isn't that not a good idea? Developing assessment, shouldn't that mean educating patients also?
Yeah, I think a good point. How topicals are used and how efficiently they're applied to the mucosa, I think is what your question addresses, can be really important, and it requires patient compliance. So one of the issues that transferring from a research environment into the clinic, into the real world, is that patients are not driven by the providers necessarily to be compliant for time of rinsing and even frequency, even though it's recommended. So I think that we often end up with very optimistic looks potentially at outcomes that once they're in the real world, they are different because of how they're utilized. So I think that's really an important point. And patient-reported outcomes are being developed from a number of different perspectives to help us to gather that kind of data, and that's really an important part of what drug licensing is all about too now, as you know.
Mario.
En ce qui concerne l'effet secondaire,
With regard to side effects, in response to the initial question, Jeffrey Crawford was extremely circumspect when he talked about a relationship between the response and side effects. But the very same question cropped up for colorectal cancer with cetuximab. We felt that it was more potent despite the side effects. When with more side effects meant more efficacy, but we increased the doses and it didn't actually work.
Last part of what you asked because of the translator, but maybe I agree, and maybe Jeff can answer that too.
Réponse de Jeffrey.
I think there is a well-established relationship between cytotoxic chemotherapy and neutropenia, and also with mucositis. And at least for neutropenia, there's a clear correlation with improved outcomes. So it's not that neutropenia per se helps people live longer, it's just that it's a marker, a pharmacodynamic marker that you've achieved enough of a dose of cytotoxic chemotherapy to hopefully be effective against the tumor. And I suspect the same relationship might exist for mucositis. Yeah. I think Janice Gabrilov showed that in some of her early work with GCSF.
Yeah, I think it could, but I'm not aware that it's actually been shown.
I agree only a little bit because the data, in fact, of the neutropenia has also been verified by the dose given. And I think there's very early data from Bonadonna showing that if you are less than 85% of the calculated dose, you don't get the result expected, regardless whether you have neutropenia or not. So I think neutropenia is just a marker of the amount given, and that's all. And I don't think you can extrapolate that here, that it's just a marker. Because at least in EGFR, in colorectal cancer, it has not been verified, where the study was done in order to find out, by increasing the dose, if you get more toxicity, do you get a better result on the treatment?
In head and neck, I think one of the big issues is that with radiation therapy, almost everybody develops mucositis in any event. It's the degree, the severity, and the duration that's altered. So it would be hard to find, I think, in head and neck. It may be much simpler in, say, transplant, where we could use that as a marker of more direct toxicity than head and neck alone.
I think with skin toxicity and mucosal toxicity, there are probably a lot of individual factors. I think perhaps the bone marrow is a more consistent reserve. And it's not so much increasing the dose and showing benefit, it's that not decreasing dose. Yeah, I think that's what we learned.
Okay, we agree.
Non, c'est fini, Mario. Merci beaucoup. Y a-t-il une question pour Lisiane?
Thank you very much. Any questions for Lisiane Marté? I'd like to hear Richard's opinion about Lisiane Marté. In terms of physiopathology, in terms of treatment, there are lots of similarities between nausea on the one hand and hiccups on the other, even though we saw that nausea and vomiting is a factor in hiccups, but there are other factors as well, other causes. But in terms of treatment, the two converge to some extent. So do you have any idea about using NK1s for treating hiccups? We touched upon that a little bit. I didn't find any information about such treatments for hiccups. What about preventative treatments for nausea and vomiting? Can this have an impact on the onset of hiccups? Any comparative studies? Nope, not to my knowledge. I looked at the bibliography, but I didn't find any preventive therapy that could actually stop hiccups from taking place, from happening.
Interesting to look at the NK1 studies, And in the original study in cisplatin-treated patients, there is a small incidence of hiccups with the patients treated, which is greater in those patients treated on the NK1 arm. It's not much greater, but it's a little bit greater. And as you presented, it's almost exclusively in men. So I think there is little reason to believe in men that NK1s would prevent hiccups or would be useful for the treatment of hiccups. On the other hand, in the 866 patient breast cancer study, there are no differences between the NK1 treated arm and the arm that did not receive aprepitant. And of course, this was all but one patient were women in the study. So the mechanism of action that may be there is that since the NK1 delays the metabolism of dexamethasone, it may simply be that there was more exposure to dexamethasone in that arm. Now, if that's true, then there is a dose effect with the corticosteroid in producing hiccups. Maybe that's true, maybe that's not. And I don't know that paper that you presented that shows methylprednisolone with a lower incidence of hiccups, but it may be because there was not an equivalent glucocorticoid effect of methylprednisolone. And if that is true, then it's really not the difference in the drugs. It's simply the patient exposure to glucocorticoid activity. I also agree that we really don't have a good treatment for hiccups. I've never seen baclofen to be very effective, and this difference between men and women is very curious. And as you say, maybe it has to do with the fact that it's easier to prevent emesis in men, more difficult in women, and there is this correlation with hiccups. I don't know.
Des arguments.
The authors who compared methylprednisolone with DEXA suggested the following explanation. Methylprednisolone leads to an improvement in hiccups because dexamethasone clears the blood-brain barrier better than methylprednisolone, and this could have a central effect that methylprednisolone doesn't have. That was their explanation. Actually, it's a proposal. That was their proposed explanation.
That is a proposal rather than an explanation. Because we know that irritation of the phrenic nerve causes emesis and does not require any central activity. So it is curious, and the entire hiccup literature beyond oncology is also curious.
Merci. Il est certain que devant ces
Thank you very much. Now, based on these questions, I'm sure that we're looking forward to hear more from Lisiane over the next few years. She can discuss.